Hello everyone, my name is Eileen Regan. I'm the CCO at Examen, and it's my pleasure to welcome you to our 7th webinar in our male fertility series. So as you may know, the webinars take place on a monthly basis, and we're joined each month by an expert in their field of fertility treatment and therapies. And the event's open to all, so we have a wide range from professionals, academics, embryologists, urologists, as well as the men, couples and individuals who are on their own fertility journey. The views presented in the webinars are the views of our speakers and not necessarily of our company Examen. And you're all very, very welcome to join us today. We're very excited to introduce you to our speaker, Professor Sandro Esteves, founder and medical director of the Androfert Andrology and Human Reproduction Clinic in Campinas, Brazil. And our chair today, Professor Sheena Lewis, is the founder and CEO of Examen, an honorary professor at Queen's University Belfast, where for the past 25 years, she has dedicated her research into novel tests for male infertility. Just a little bit of housekeeping to get us started. And I'm going to let Professor Lewis introduce you all in a bit more detail to Professor Esteves. So we'll start with a short introduction from Professor Lewis, and then we'll hand over to our main speaker for the main event of the day. And then at the end, we will allow 15-20 minutes for Q&A. So please do pose your questions throughout the talks using the Q&A panel, not the chat function. If you do have any technical issues, please use the chat, but use the Q&A for the questions. The reason being, then you have the opportunity to rate the questions, and then we'll be able to make sure that we prioritize those. If you do experience technical difficulties, please use the chat. We'll do our very best to help you. But sometimes we're at the mercy of Zoom. So our attendees will be muted throughout. Videos are enabled for our speakers only. And also all the events in the series are recorded and will be available on our events page on the Examen website tomorrow, so following each session. So it means you can also go back and watch any of the sessions that you may have missed in the series. So just give us 24 hours for the recording to be uploaded. And then also 1 CPD point will be awarded for everyone attending the 1-hour event, and a certificate will be circulated to you following the event in 1 or 2 days' time. So at the end of the session, you'll be invited to rate it. Please do so, and we welcome your feedback on the session, as you know, we're happy to take suggestions for future sessions. So without further ado, I will now hand over to our chair, to Professor Sheena Lewis, to start the session.
Good evening, everyone. It's a pleasure to be here. And if we have technical difficulties tonight, blame it on the fact that I'm at a meeting in the north of England, and it's very blustery and very rainy up here. And I've been having a few problems with my internet this afternoon. So you can all see the first slide, I hope. And you know that the title tonight is Using Surgically Retrieved Sperm in Fertility Treatments. And I know this is very much a hot topic. And I'm having problems again. Why can I not share my screen? Yes, hello. So our mission, as you know, for those of you who've been with us in previous webinars, is to raise awareness for male infertility. And this is something that's really very important to us, because when we talk to fertility clinics and we talk to patients, there's so many basic things that they just don't know about male infertility. And if they don't know, then they can't ask and they can't find out more about their own particular problems. So what we want to do is to tell people more, and that's the reason for these webinars, to provide men with knowledge and advanced testing opportunities to be tested more than is a routine workup in just a basic one. And we also want to demonstrate, and have been doing so with our research over the last number of years, that if you make your sperm health better, it will improve your fertility outcomes. That's really important. As you all know, the routine testing of semen analysis is the gold standard, no doubt about it. It's very important, but it hasn't changed very much since 1940, when it was actually developed for stud animals. And it's an okay test, but it only looks at motility, morphology, and sperm counts, and it doesn't tell you anything about the actual DNA quality, which is the really important part, which makes a child look and act like their dad. In terms of our company, we've been working for about 11 years now, and we started off very small in the corner of a university pathology lab. And over the years, we have been working in the UK and in Ireland, and now we're working in a number of other countries as well. And as time has gone on, we have increased the number of staff that we have. We have rebranded. We're now called Examen. We were called Sperm Comet, and we have tripled our staff in the last year and doubled our lab space. And of course, along with that goes a lot of regulation. So we now have an ISO 13485, which is an indication of the quality of our service and our tests. And we're working towards an IVDR, which is an in vitro diagnostic regulation necessary in Europe. And we'll be submitting that early next year. Why would anyone want to use our company? Well, I think one of the reasons is because exact tests can diagnose male infertility more accurately than a semen analysis. As you know, 25 to 30% of couples are given a diagnosis of unexplained infertility, which means that no one really knows what's wrong, although they do know there's a problem. And we have found that about 40% of these couples have high DNA damage. So that's one of the reasons why couples have unexplained infertility. The company is based on publications through academic, non-commercial work over the last 25 years. And something that's special about our Comet assays, it's called Comet academically, it's called Exact if you're looking at our branding, just to prevent any confusion. And we're the only ones who actually report the DNA damage per sperm. We can detect single and double-stranded DNA breaks. And over the 10 years that we've been commercialized, we are now working in 80% of the private sector in the UK. I think one of the most important things that we can do for men is allow them to take back control of their fertility and to be equal players. And that's really important because I certainly believe that men have been emasculated within the fertility arena and used just as sperm donors. And no one has really cared about examining them or taking their histories or looking for ways to actually improve sperm quality. And that's something which we think is really important. One thing that's absolutely wonderful is that over the last couple of years, we have become routine within a lot of international fertility guidelines, the European Association of Urology, the ESHRA guidelines, the American Association of Urology. All of these are now saying, yes, a semen analysis is the first thing you've got to do, but it's not the only thing you've got to do, particularly if a couple is suffering from miscarriage or from, as I said, unexplained infertility. ASRM and the American Urology Association over the last couple of years are really stressing this now, that the male partner ought to be evaluated by a male reproductive expert. Now, to those of you who have an interest in this, perhaps that's not unusual, but actually that's something which hasn't been happening for the 40 years in which we've had IVF. It's just the woman who's been examined, the man has not. So this is a major step forward. And then the most exciting thing that happened a couple of months ago was that the latest WHO manual that came out said that DNA testing is one of the most promising new biomarkers, and in both basic and in clinical andrology. And DNA testing has now been included as an extended examination for couples in certain circumstances. Take that whichever way you will. Now, tonight we have the tremendous pleasure of having Professor Sandro Esteves with us. And it's really hard to tell you how many qualifications one person could have, because Professor Esteves is a very, very well qualified chap altogether. He's not only a clinical and scientific director, as we told you earlier, he's got twice as many papers as I have. He's got 70 book chapters. He's a urologist and an IVF consultant, and he has been the Alumni of the Year Award winner from Cleveland Clinic Center for Reproductive Medicine, and has had the Star Award for the American Society of Reproductive Medicine over the last 5 years. There is no better person to tell us about surgical retrieved sperm than he is, because he has written so many publications on this. And he's also an amazing person if you have him in a debate. And I know I've read the papers where there's been a difference of opinion, and he is giving the point of view that he thinks testicular sperm ought to be used. Others are giving the point of view that they ought not to be used. And he has some very, very tightly worded arguments. I've had the pleasure of co-authoring a few things with him, and this has been an absolute pleasure, because he is so easy to work with and is so absolutely accurate in everything he says. So I think we're in for a very special webinar this evening. And I'm just going to hand over to him now and hope that you are all going to enjoy the next half hour. Thank you, Professor Esteves.
Thank you very much, Sheen and Ellen, for this kind introduction. I'm delighted to participate in today's webinar on use of surgically retrieved sperm in fertility treatments. Before I start, I want to thank you for inviting me to participate, and also to all of you who took the time out and are here with us today. Here is an outline of what I'll be covering the next 30 minutes. I will discuss sperm retrieval techniques for different clinical situations, including the use of fresh versus frozen surgically retrieved sperm, and also the best timing of sperm retrieval in relation to oocyte retrieval. I would like to discuss the situations where testicular sperm may be considered in preference over the ejaculated sperm when both are available. But instead of a formal talk, my presentation will be based on real clinical case scenarios. Before I do that, I want to provide you with some background information. As you know, sperm retrieval has been classically used to harvest sperm from the epididymis and testes of men with azoospermia seeking fertility. And after the recovery of epididymal or testicular sperm, ICSI is mandatory, because this sort of sperm cannot fertilize the oocyte by conventional IVF. However, as ICSI experience accumulated, an association between poor sperm quality and suboptimal ICSI outcomes became apparent. As a result, sperm retrieval in indications other than azoospermia has been investigated as a way to obtain sperm of better quality potentially. Both percutaneous and open sperm retrieval procedures can be used to harvest sperm from the epididymis or testes. These methods are widely known by their acronyms: MESA, PESA, TESA, TESI, and micro-TESI, based on the target organ, epididymis or testes, use of open or percutaneous approaches, and whether or not microsurgery is utilized. In men with obstructive azoospermia, spermatogenesis is normal and the sperm can be easily retrieved from the epididymis or testes. Despite being more technically demanding, MESA yields a higher number of motile sperm than does PESA. So it offers the possibility of cryopreserving larger quantity of sperm. The MESA approach also enables multiple ICSI cycles without the need for repeat sperm retrieval. MESA is currently the sperm retrieval method of choice in our center for men with obstructive azoospermia. By contrast, in men with non-obstructive azoospermia, the testis is the target organ because sperm production, if present, is generally minimum and restricted to focal seminiferous tubules. In the scenario of non-obstructive azoospermia, open methods are preferred over percutaneous methods due to the higher sperm retrieval success rates and lower complication rates. Now, in non-azoospermic men, I mean men with sperm in the ejaculate, both percutaneous and open sperm retrieval procedures can be used to harvest sperm from the seminiferous tubules. In this scenario, the testicle rather than the epididymis is the target organ because it has been shown that testicular sperm have better chromatin integrity than epididymal sperm. We prefer TESA for men with elevated sperm DNA fragmentation and micro-TESI for cryptozoospermic patients. Now, coming back to obstructive azoospermia, the type of sperm retrieval technique and the cause of obstruction have little impact on sperm retrieval success. Also, either fresh or frozen thawed sperm can be used for ICSI with compatible results. However, in non-obstructive azoospermia and also non-azoospermia patients, the published evidence concerning the use of fresh or frozen thaw retrieved sperm is still limited and results are mixed. So dealing with challenging male infertility cases is part of my routine, which I'm sure is also of yours. Today, I would like to take the opportunity to discuss a few of these cases with you. I want to start with the case of this couple who came to seek fertility treatment with me. It's a case of infertility due to a pure male factor of genetic origin. Non-mosaic Klinefelter syndrome is the underlying etiology explaining azoospermia. Klinefelter syndrome is the most common genetic anomaly in male infertility patients. Up to 10% of the patients with non-obstructive azoospermia have Klinefelter syndrome as the causative factor. The 47XXY karyotype confirms the diagnosis. And although these patients have spermatogenic failure, which is irreversible and untreatable, it does not necessarily mean sterility. In fact, the reported success in retrieving testicular sperm in these patients ranges from 22 to 52%. And pregnancy has been achieved in up to 50% of couples subjected to ICSI with the patients on sperm. The patient age, baseline testosterone levels, and the method to harvest sperm seem to affect the chances of obtaining sperm, but the evidence is still mixed. Important questions here relate to the sperm retrieval technique and whether the retrieval should be coupled with oocyte pickup or not. The clinical management of men with non-obstructive azoospermia seeking fertility, including Klinefelter syndrome patients, has been a tremendous challenge for all andrologists, urologists, and reproductive medicine specialists. In this article I published in the Asian Journal of Andrology, I discussed in detail my personal experience on the matter, including the lessons I've learned over the last 25 years. In practical terms, I use a 5-step algorithm to manage my patients with non-obstructive azoospermia, including the Klinefelter syndrome patients. This algorithm includes, first, the differential diagnosis with other types of azoospermia. Second, patient counseling about the chance of sperm retrieval success and achieving biological parenthood, which includes the use of genetic testing for diagnostic purpose and treatment guidance. Third, consideration for medical therapy to increase sperm retrieval success. Fourth, application of the most effective and efficient sperm retrieval technique. And lastly, the use of state-of-the-art laboratory techniques for handling testicular sperm and cultivating the embryos resulting from testicular sperm injections. Concerning the case study, I want to briefly touch on the 3 last steps. Let me start discussing what can be done before the sperm retrieval. Indeed, the uncertainty of sperm acquisition makes attempts to improve sperm retrieval success very desirable. Many patients with non-obstructive azoospermia, including Klinefelter syndrome patients, have hypogonadism and may lack adequate levels of intratesticular testosterone that are essential for spermatogenesis in combination with good Sertoli cell stimulation by FSH. Although the evidence in this matter is not unequivocal, case series and a few cohort studies have suggested that testosterone optimization may increase sperm retrieval success rates. For this purpose, selective estrogen receptor modulators, aromatase inhibitors, HCG, and FSH have been used off-label to manipulate male reproductive hormones and optimize intratesticular testosterone production. The primary goal is to improve sperm retrieval success rates. And although there's a lack of randomized controlled trials on this matter, thus making it difficult to give clear recommendations, we have discussed with our non-obstructive azoospermic patients, including those with Klinefelter syndrome, the potential benefit of using off-label medical therapy to optimize intratesticular testosterone production and FSH action before sperm retrieval. Our treatment protocol relies primarily on recombinant HCG to boost intratesticular testosterone production. Adequate levels of intratesticular testosterone are critical for spermiogenesis, spermatogonia proliferation, and upregulation of androgen receptors. When we give HCG treatment, it may also reset the baseline elevated FSH levels to normal levels. In fact, elevated FSH levels are quite typical in patients with non-obstructive azoospermia. The FSH reset may lead to increased expression of FSH receptors and might improve Sertoli cell function. We follow up our patients with a monthly hormonal assessment, which includes measuring testosterone levels, FSH, estradiol, LH, and 17-hydroxyprogesterone levels as well. We add an aromatase inhibitor in the course of treatment when the testosterone to estradiol ratio, testosterone assessed in nanograms per deciliter, estradiol in picograms per ml, turns less than 10. We also add recombinant FSH when after HCG treatment, the FSH levels drop to below 1.5 international units per liter. The treatment goal is to keep testosterone levels and FSH levels within the normal ranges. The next step is to apply the sperm retrieval technique that provides the best chance of finding sperm. In our hands, microtessi is the technique of choice for retrieving sperm from men with non-obstructive azoospermia. I have a short movie that highlights its key surgical aspects. The key surgical aspects in microtessi includes use of operating microscope and microsurgical technique. We perform microtessi on an outpatient basis. Second, ample exposure of testicular parenchyma allows dissection and identification of enlarged seminiferal tubules that are more likely to have sperm production. Also, importantly, is to consider that the removal of small fragments by microtessi instead of large biopsies as done typically in conventional tessi has several advantages. Less tissue removal makes it easier for embryologists to process the specimens and search for sperm. It also reduces testicular damage and the risk of exacerbating testosterone deficiency, which is quite common in men with non-obstructive azoospermia. Overall, the relative risk of finding sperm by microtessi is 1.3 times higher than with conventional tessi. And the number of patients needed to treat by microtessi versus conventional tessi to obtain one additional positive sperm retrieval is about 8. Microtessi is even more advantageous in patients with the worst testicular histopathology phenotype, I mean, Sertoli cell only. In these cases, data from controlled studies show that the relative risk of finding sperm is 2.7 times higher with microtessi than conventional tessi, with a number needed to treat of about 4 to obtain one additional successful sperm retrieval. Interestingly, most patients with Klinefelter syndrome have Sertoli cell only as the predominant histopathology pattern. Microtessi, in my opinion, is the optimal sperm retrieval for them. It not only increases the chances of finding sperm, but also minimizes testicular damage and therefore the risk of exacerbating testosterone deficiency, which is quite common in men with Klinefelter syndrome. I usually perform microtessi as a separate procedure and freeze the retrieved sperm. In our hands, fresh and frozen thaw testicular sperm do similarly at ICSI. Our results are consistent with the literature, which shows that fertilization rates and pregnancy rates do not differ substantially when fresh testicular sperm of men with non-obstructive azoospermia is compared with frozen thawed sperm. We usually freeze testicular sperm using vitrification devices like the cell slipper shown in this slide. The cell slipper consists of an outer vial, an inner tray, and a screw cap. What we do is that we eject motor sperm into the droplet of the tray with a microinjection pipette. The tray is placed into the vial, and the vial is firstly frozen on liquid nitrogen vapor, then submerged in liquid nitrogen for storage. This approach is advantageous from a quality management perspective because it allows ICSI to be carried out without having to program microtesting concomitantly to the oocyte pickup. So in summary, for a Klinefelter syndrome patient like this, I feel HCG-based therapy should be considered for at least 3 months before the sperm retrieval. In our settings, the sperm retrieval is usually carried out by microtesting as a separate procedure. ICSI would then be performed with cryopreserved sperm. However, if I have donor sperm available as a backup, I like to combine microtesting and oocyte pickup on the same day. As a note of caution concerning the use of hormonal stimulation in men with non-obstructive azoospermia, the current European Association of Urology Male Infertility Guidelines do not recommend its use outside clinical trials. However, this recommendation stems primarily from the lack of evidence from randomized controlled trials, as I mentioned before. One thing that it's important to consider concerning the clinical practice guidelines is that their primary objectives are to translate the best evidence into practice and to provide clinicians a framework of standardized care. However, I feel that the decision to perform a particular intervention should be individualized for every patient. In this sense, clinical autonomy and physician judgment should be taken into account. Along these lines, based on the overall favorable results of medical therapy in cohort studies and the dramatic adverse impact of non-obstructive azoospermia to couple infertility, my personal opinion is that we should not refrain from considering hormonal modulation for selected patients with non-obstructive azoospermia, but we need to discuss with our patient the limitations of the existing evidence and the possible clinical benefits and risks of this intervention. So finally, to optimize ICSI reproductive success, we use a predictive model called ART calculator to estimate the minimum number of metaphase 2 oocytes we need to have at least one euploid blastocyst for transfer. The ART calculator estimates the individualized probability of blastocyst euploidy per metaphase 2 oocyte as a function of female age and type of sperm used for ICSI. Female age and type of sperm used for ICSI were the most relevant variables impacting the probability of embryo euploidy according to our published data. Specifically, we found that the use of testicular sperm from men with non-obstructive azoospermia negatively impacted the probability of embryo euploidy per metaphase 2 oocyte. So it means that we will need more oocytes to obtain at least one euploid blastocyst. Our model has been validated externally in a recent study involving 2 European clinics. Here you can see how the calculator works. So I have a short video that shows that pre-treatment, all we have to do is provide the patient's age and the type of sperm used for IVF ICSI. And then the user sets the probability of success we want to have in our estimations. Then with a single click, the calculator estimates the number of metaphase 2 oocytes needed to obtain at least one euploid blastocyst with the correspondent range. Now suppose the predictive number of metaphase 2 oocytes is not achieved. In that case, the calculator can be used to estimate the chances of having a euploid blastocyst with the number of metaphase 2 oocytes ultimately obtained. As we know well, a euploid blastocyst has 50 to 60% chances of implanting into the uterus across all maternal age groups. So what we do is that we plan the ovarian stimulation and the overall ICSI treatment with the mindset of obtaining the optimal number of oocytes to maximize treatment success. Now I would like to move to another case of a young couple with tubal factor infertility with a history of repeated IVF failure, despite the husband having good semen parameters assessed on a routine semen analysis. And also the female partner had good oocyte retrieval and embryo development. So in cases like this, we order sperm DNA fragmentation testing. This patient had 45% of the cells with the DNA fragmentation in the neat semen, which, as you know, is quite elevated. So the questions to answer in this case are the following. Should testicular sperm be considered for ICSI over ejaculated sperm? And if so, what sperm retrieval technique and how to time sperm retrieval and oocyte pickup? I feel thinking about sperm DNA fragmentation in the context of ART is important. This is the most extensive systematic review and meta-analysis examining the impact of sperm DNA fragmentation on IVF and ICSI outcomes. It included 70 studies and over 10,000 IVF ICSI cycles. What we see in this study was that a modest but significant association between sperm DNA fragmentation and pregnancy rates was observed, regardless of whether IVF or ICSI was used as the insemination method. The magnitude of effect size varied according to the assays used for measuring sperm DNA fragmentation. In this study, for instance, the alkaline comet assay was the test with the best discriminatory power. Additionally, when the authors performed subset analysis, only including studies where patients with female infertility factors were excluded, the odds of predicting a successful pregnancy from the level of sperm DNA fragmentation were amplified, which stresses the importance of sperm DNA fragmentation as a relevant paternal factor contributing to infertility and ART outcomes. Sperm DNA fragmentation also increases the risk of miscarriage in pregnancies achieved with either conventional IVF or ICSI. In one of the meta-analyses, which included about 3,000 patients, the reported odds ratio meant that if the average miscarriage rates in a given clinic range between 10 to 15%, these rates will reach 23% in couples treated with sperm of men with elevated sperm DNA fragmentation. Now let's think in practical terms. The net effect of neglecting elevated sperm DNA fragmentation for a fertility clinic performing, let's say, 1,000 IVF ICSI cycles per year with an average clinical pregnancy rate of 40% would be a loss of approximately 80 potential pregnancies, ultimately resulting in a live birth rate reduction of up to 15%. Could you afford such a loss? I can't. So I do care about sperm DNA fragmentation and test my patients routinely. Our data show that over 50% of our patients have sperm DNA fragmentation values of 20% and higher. And 25% of our patient population have values of 30% or greater. So along these lines, emerging data indicate that IVF couples with elevated DNA fragmentation may benefit from a combination of testicular sperm extraction and ICSI approach, so-called TESTI-ICSI. So specifically, when we look into couples with failed IVF-ICSI cycles and high sperm DNA fragmentation beneath semen, we have some data to guide our practices. At the moment, data from 3 comparative cohort studies suggests that pregnancy rates increase when testicular sperm over ejaculated sperm are used for ICSI. So the same trend is noted in the comparative studies that included only couples without a history of failed ART. One of these studies was carried out by our group that I want to show you briefly. This was a prospective cohort study comparing testicular sperm ICSI versus ejaculated sperm ICSI among couples without a history of IVF failure, whose partners had elevated sperm DNA fragmentation, 30% or greater, measured by the sperm chromatin dispersion test. So in this study, to achieve 1 additional delivery, we found that 5 was the number needed to treat by testing ICSI versus ICSI with ejaculated sperm. Although sperm retrieval in this scenario means more invasive treatments for the male partners, it may translate into fewer treatments for the women, who generally carry the heaviest treatment burden. A possible explanation for the better ICSI outcomes with testicular sperm relates to the significantly lower sperm DNA fragmentation in testicular specimens than ejaculated counterparts. In our study, we compared sperm DNA fragmentation rates between testicular and ejaculated specimens of same men. It was a subgroup analysis that included 81 patients. We found that sperm DNA fragmentation was about 80% lower in testicular than ejaculated sperm. The sperm chromatin susceptibility to oxidative stress, particularly during epididymis transit, might explain the lower testicular positivity for sperm DNA fragmentation than that found in the ejaculate. This is the algorithm I use in my patients with elevated sperm DNA fragmentation who are candidates to ART. I feel that the laboratory evidence of defective sperm chromatin should prompt a detailed male infertility evaluation to identify potentially correctable underlying factors. So just as all infertile women are treated by doctors with specialized gynecological training and expertise, all infertile men should be evaluated by specialists in male reproduction. In cases where no causative factor is identified, or elevated sperm DNA fragmentation persists after treatment, I feel consideration for sperm retrieval and ICSI with testicular sperm over ejaculated sperm should be given, particularly to couples experiencing IVF-ICSI failures for no apparent reasons. So what I'm discussing with you today can be found in this recently published clinical practice guideline developed by a multinational group, including urological surgeons with expertise in male infertility, scientists involved in the development of sperm DNA fragmentation tests, and reproductive endocrinologists. From the UK, we had the privilege to have Professor Sheena Lewis among the authors. And this is an open access article that you can find in PubMed. So accordingly, testing has value in couples experiencing unexplained IVF-ICSI failures. And equally important, I feel that we should consider testing before commencing IVF and ICSI. The information provided by the test may be useful for patient counseling and to guide clinical management. If sperm DNA fragmentation is high, the patient has to be evaluated by a reproductive urologist to rule out any male factor associated with sperm DNA fragmentation. In cases where no causative factor is identified, or elevated sperm DNA fragmentation persists after treatment, ICSI would be preferred over conventional IVF, and consideration for using testicular sperm in preference over the ejaculated sperm may be valid to overcome unexplained ICSI failures. So the evidence concerning the beneficial effect of medical and surgical interventions to reduce sperm DNA fragmentation is increasing steadily Today, I will not have time to go through them in detail, but I invite you to look at this recent paper I published in Andrology, which summarized the main studies. But just to give you one example, consider the case of varicocele, which is a common congenital abnormality associated with oxidative stress, sperm DNA fragmentation, and infertility. Our group just reviewed the literature concerning the effect of varicocelectomy on sperm DNA fragmentation rates. We found that varicocele repair decreased sperm DNA fragmentation rates as early as 3 months after the intervention. The weighted mean difference was about 7%, resulting in a 30% relative reduction in sperm DNA fragmentation rates from baseline levels. The results were consistent for the study using the most common sperm DNA fragmentation assays and also microsurgical varicocele repair. We also showed that the treatment effect was more pronounced in men with baseline sperm DNA fragmentation levels above 20%. We also performed a meta-regression analysis that indicated that sperm DNA fragmentation decreased after varicocelectomy as a function of preoperative sperm DNA fragmentation levels. So the higher the baseline sperm DNA fragmentation rate, the higher the reduction in sperm DNA fragmentation postoperatively. So coming back to our case discussion, in summary, for couples undergoing IVF-ICSI whose male partners have high sperm DNA fragmentation, I consider sperm retrieval and use of testicular sperm for ICSI, particularly to those couples with ART failure of no apparent reasons. So importantly in this case, sperm retrieval should not be applied indiscriminately. The patient has to be evaluated by a male infertility specialist and measures taken to identify and correct the underlying factor associated with elevated sperm DNA fragmentation, if possible, of course. In our hands, percutaneous sperm retrieval, I mean TESSA, is the method of choice for harvesting testicular sperm from non-azoospermic patients with elevated sperm DNA fragmentation and sperm concentration of 1 million per ml or above. We prefer fresh over frozen testicular sperm, so it means sperm retrieval and ICSI with testicular sperm are carried out on the same day of the oocyte pickup. The reason relates to the fact that sperm freezing might negatively affect sperm chromatin integrity, although the evidence is not unequivocal. So this is like we do in our center, the testicular aspiration using, a syringe holder that you can see here. This is a chemical syringe holder and a percutaneous sperm retrieval. Let's now move to another case of a relatively young couple whose male partner had only rare sperm in the ejaculate, a condition that we know well as Cryptozoospermia. So the questions here are, should sperm retrieval be considered and testicular sperm used for ICSI over ejaculated sperm? Yes, no, or only after ICSI failure? And if yes, what sperm retrieval techniques and how to time sperm retrieval and oocyte pickup? So in couples with Cryptozoospermia, the existing evidence suggests that sperm retrieval and testicular sperm ICSI improved the likelihood of achieving good quality embryos, implantation, and pregnancy. However, the number of and quality of trials and also the number of patients included in the available studies are lower than that of the sperm DNA fragmentation scenario that I showed you previously. Moreover, sperm DNA fragmentation testing is hard to be carried out when the sperm numbers are too low, making it difficult to confirm if testicular sperm have better DNA integrity than ejaculated sperm in patients with Cryptozoospermia. So my personal approach in the Cryptozoospermia scenario is that to consider testicular sperm ICSI only after failed ART. And like in the sperm DNA fragmentation scenario, we only use sperm retrieval after a complete male evaluation and treatment of any underlying condition possibly associated with Cryptozoospermia. For example, varicocele, gonadotoxin exposure, and endocrine disorders. In such cases, it may be hard to retrieve sperm by needle aspiration because intratesticular sperm production is focal. So our approach is to do a microtesting, although conventional testing might also work well to harvest sperm. We perform sperm retrieval and oocyte pickup on the same day, but it is still to be determined if fresh sperm serve better than frozen sperm in this condition. Our last case of today concerns a young couple with unexplained infertility and IVF failure twice due to poor embryo development. In both cycles, the embryos were arrested and no blastocysts were available for transfer. So in a case like this, I would like to have answers for the following questions. Is there a hidden paternal factor? Would you consider sperm retrieval and testicular sperm for ICSI? And if so, what technique and when? So firstly, poor embryo development can happen due to multiple non-exclusive factors. In case like this, we perform a causative effect analysis like the one shown in this fishbone diagram. This sort of diagram is helpful in logically organizing possible causes when we have a specific problem because it graphically displays these problems in detail. The 6 critical factors affecting embryo development, namely equipment, procedures, materials and reagents, system, human resources, and patients should be evaluated. A paternal factor contributing to poor embryo development may be plausible, but other factors should be ruled out. In that case, I would certainly check for sperm DNA fragmentation. Interestingly, about 17% of our patients have high sperm DNA fragmentation despite good semen parameters on a routine semen analysis. So paternal factors, in particular sperm DNA fragmentation, may adversely impact embryo development, although the evidence is not unequivocal. It has been shown that severe sperm DNA fragmentation may be related to double-stranded DNA breaks. We know that double-stranded DNA breaks are difficult to be repaired by the oocyte and may cause embryo arrest. In the oocyte donor model, sperm DNA fragmentation was shown to impair blastulation rates. And finally, embryo development assessed by time-lapse imaging was also shown to be disrupted by elevated sperm DNA fragmentation. So in summary, I feel sperm DNA fragmentation is valid to evaluate a paternal factor contribute to unexplained poor embryo development. Sperm retrieval and testicular sperm for ICSI may be considered, but elevated sperm DNA fragmentation has to be confirmed in such cases. So this consideration implies that a complete male evaluation and treatment of any underlying condition associated with sperm DNA fragmentation was carried out. TESA would be my preference, as it is a straightforward method to retrieve testicular sperm percutaneously, particularly in patients with good sperm count, like in this case. And as I said before, we prefer fresh over frozen thawed testicular sperm in cases involving sperm DNA fragmentation. So that brings us to the end. But before I finish, it's important to realize that there are still knowledge gaps to be filled and to improve our decision-making concerning the use of surgically retrieved sperm in fertility treatments. We need more data from high-quality studies, controlling for relevant confounders to support, for instance, hormonal treatment before the sperm retrieval in patients with non-obstructive azoospermia, and also testicular sperm in patients with elevated sperm DNA fragmentation, Cryptozoospermia, and unexplained poor embryo development. But while we should certainly take these limitations into consideration, I feel we should not refrain from using the best available evidence to guide our decisions in the best possible interest of our patients. Finally, I'd like to give you a few take-home messages for you to consider. Firstly, male infertility has been increasingly recognized as a medical condition and public health concern. Secondly, its prevention and management are integral components of comprehensive sexual and reproductive health services. Lastly, a well-conducted male infertility workup has the potential to reveal relevant underlying medical and infertility conditions, many of which may be treated or alleviated. And in cases of irreversible conditions, the male infertility workup may help guide the optimal application of assisted reproductive techniques. So the final goals are to positively impact the overall patient health, the couple's pregnancy prospects, and the offspring's well-being. Thank you so much for being with me today. I would be very interested to hear your comments and answer your questions. Thanks a lot.
Thank you very much. That was absolutely fantastic. You gave us such a lot of information there. And I'm really glad that those slides are going to be on our website, because I, for one, will certainly be wanting to have another look at them. Can I ask you a couple of questions first? And these are questions which I have heard going around fertility clinics in the UK, because as you know, there's a hesitance to move towards the use of testicular sperm for men who have sperm in their ejaculate. And one of the questions is that there's a concern about embryo cleavage, for example. When people are looking at embryoscopes and they're looking at cleavage, they say that the cleavage is faster to reach a blastocyst stage when you're using ejaculate sperm than when you're using testicular sperm. Would you like to comment on that?
I think that we need to consider, the embryo development in different scenarios. It might be the case that we have differences in embryo development, even when we use different culture media. We have been observing time-lapse imaging in our center, and we, found differences in terms of embryo development just by switching the culture media we use. So I think we need to be careful actually to judge embryo development of testicular versus ejaculated sperm just based on time-lapse imaging. But with the data we have, it's quite clear. We see, absolutely consistent lower sperm DNA fragmentation rates in testicular specimens. Patients with confirmed elevated sperm DNA fragmentation in the neat semen. And we see that these patients have overall reduced miscarriage rates and increased live birth rates by ICSI with testicular sperm. This data comes from our prospective study, but we consistently report and record data of patients in our clinic, and we are happy with the results we have obtained.
Great. Okay, thank you very much. Here's a question from the audience, and this is about the effect of varicocele repairs on live births rather than the effects on reducing sperm DNA fragmentation. I don't think you mentioned that, but I have a pretty good idea what you're going to say.
Well, the varicocele is a hot topic. There are several ways of looking into the problem. The varicocele affects the testicle. So I think that the main organ for us to look at is the testicle and semen parameters, sperm functional parameters. But at the end of the day, what the clinician wants to know is that if repairing a varicocele actually will improve live birth rates. So we need to look at the problem into different aspects. So we can then look into spontaneous pregnancy. And we have data even from the Cochrane review showing that varicocelectomy improves pregnancy rates in subfertile couples. So we have data from some randomized control trials pointing to that direction, although the data is not absolutely high quality. So the Cochrane review made some comments regarding that. But we need to consider that when we talk about varicocele, it's important to distinguish subclinical varicocele, in which the urological guidelines do not routinely recommend treatment, to clinical varicoceles. The varicocele that the clinician, the urologist, can actually feel during physical examination. These are the varicoceles that deserve consideration for treatment. So the other aspect is that, we go for ART. And then the question is, shall I fix a varicocele before ART? Well, We have a paper published in Journal of Urology a few years ago in which we looked into that aspect. And we found that treatment of varicocele before ICSI actually reduced the likelihood of miscarriage and increased live birth rates in our patient population. It was a retrospective data analysis. So to my knowledge, we don't have a randomized controlled trial actually exploring that issue. For DNA fragmentation, in the paper that I mentioned in my slide, which is available online in Fertility, we try to look into live birth data, Sheena, but
Yes.
there are few studies actually looking to that aspect. However, there are a few studies showing that decrease in sperm DNA fragmentation translates into an increase in live birth rate. So although we don't have robust data yet, I would like to say that there is, interesting information consistently linking reduction in sperm DNA fragmentation and then improvement in the likelihood of achieving live birth in ART.
Thank you. I'm sorry to rush you, but I know we're coming to the end of our time. I have one more pressing question from a member of the audience, and that is, what do you think about using IMSI or Zymot on testicular sperm? Would that
this is a very interesting,
Yeah,
absolutely. This is a very interesting question because this is something that eventually we could do in the lab to actually improve the outcomes. Well, I think the best information we have at the moment shows that testicular sperm might be the way to go. If we look at the paper published by the group of the Australian group of Bradley, they published a study in andrology in which they compared interventions for patients with high sperm DNA fragmentation. They looked into IMSI, ICSI, and testicular sperm ICSI. In that study, the author showed that the highest live birth was achieved by using testicular sperm. But I feel that there's room for laboratory interventions to reduce sperm DNA fragmentation, although the data is not completely consistent. As you know, the paper on ICSI to kind of improve live birth, the randomized control trial in which there was UK participation, did not show, let's say, a significant difference in terms of live birth after ICSI. But I feel that there might be a role for laboratory interventions to reduce sperm DNA fragmentation.
Okay, I've got one, and this really is the final question, and this is from an embryologist, and she says, I'm an embryologist. I agree with you that men should be seen by a fertility specialist urologist. However, even in the middle of London, which is where she works, there are so few people who have this expertise. Do you think this is happens worldwide, and how can we combat it?
This is a fantastic question, the most difficult one to answer because I feel it's worldwide. I travel to different countries, and what I see is that there is genuine interest from the urological community to learn more about infertility. But for the urologists, they have a broad range of opportunities in the urological field, and infertility is kind of just a small part of it. So not all of them are really interested to kind of invest time and to study in depth infertility. I think the situation is changing. We have a program here in Brazil in which our clinic is associated with the university, and I see more and more senior urology residents interested in learning more about male infertility. But there is a long way to go, and this is a job for the urological societies, also the ART societies, to provide training and try to motivate more and more the urologists to participate. What is important thing is that the urologist should not be the technician just coming at the last minute in the center to do sperm retrieval. This is very important that this person is part of the team, being able to see the patient, conduct the male infertility workup, and improve the male health as a whole. That will not only improve potentially the success rates, what we do in the laboratory, but also the overall male health, and also the offspring that will be generated by all the treatments that we provide.
Okay, I'm advised that we still have a very large audience, and so we'll go on for another 5 minutes, if that's okay with you, Sandra. I've got another
Absolutely,
question.
my pleasure.
That would be great, thank you. This is, why would you do ICSI on a normal zoospermic male with a high DNA fragmentation? I think you probably answered this, but I'm just wondering if you could expand a little bit. What would be your explanation for that? And the example is that it's a clinical situation of secondary infertility, first IVF cycle, high DNA fragmentation, and I assume failure. Yeah. Would you do ICSI after 6 months of a healthy lifestyle with supplements?
Well, I think that we need to separate the situations. I mean, in the study we did in couples without history of ICSI failure, all patients, they had mild to moderate oligozoospermia and other sperm defects besides elevated sperm DNA fragmentation. In that particular study we published in Fertility, actually the couples had an indication for ICSI. Now, if you go for the scenario that you just mentioned, normal zoospermic man with elevated sperm DNA fragmentation, and I do this not only in this scenario, but all scenarios in which I see elevated sperm DNA fragmentation, I provide these patients a comprehensive male infertility workup. I need to do medical history to try to identify wrong lifestyle. Sometimes the patient's not telling us that he's using, let's say, serotonin reuptake inhibitor for, as antidepressant that we know could affect sperm quality and also increase DNA fragmentation. The patient could be using cannabis, which is known to increase sperm DNA fragmentation. The physical examination could show us the presence of clinical varicocele that could be treated. So I think that we need to go into more detail in the patient profile, because we can fix several of these things and allowing this couple to achieve natural pregnancy. Well, but if the couple is experiencing, for some reason, ICSI failure, and in that case, the normal zoospermia is not the only cause. Usually the indication for ICSI or IVF would be some female problems, could be a tubal factor, as I presented in one of the cases we evaluated in our clinic. And then in that case, if I have repeated IVF failure, then I will consider testicular sperm ICSI. Not for the first comers. I don't think we have evidence to suggest or consider testicular sperm ICSI for first comers when the semen analysis, at least as routinely assessed, show normal sperm parameters and elevated sperm DNA fragmentation. We need to have some more data, some more argument to offer a man ICSI and then sperm retrieval with testicular sperm.
Yes, well, what I find interesting is that even though the women are getting older, because by the time you get to a surgical sperm retrieval, usually there have been a number of failed cycles. And at that stage, the woman is older. And so initially, people I was working with said, oh, well, the advanced female age will be counteracted. It will offset any benefit that there will be by having better sperm, and you won't get a better success rate. Actually, that is not the case at all. And you have shown that, and others have shown that having really good quality sperm still gives you a better outcome, even if the women are older.
Well, I think that the data that we had, that we published, mainly concern women, not older women. I mean, the average female age in our study was about 35. But I mean, what I have to say is that we all know that female age is a major factor for IVF failure. I mean, we cannot counteract completely the chromosomal abnormalities that we have in the oocytes and embryos caused by advanced female age. But we need also to consider that we have patient population from 35 to 40 years old, in which we have patients with still adequate ovarian reserve, in which the aneuploidy rate is not so dramatically high, and that oocytes of these women will be less able to fix the DNA fragmentation that we have in sperm. So I think your point is like, when this patient population in particular, I think we need to pay attention of sperm DNA fragmentation, because I mean, if I have a very young patient, let's say the lady has 30 years old, I know that even if the sperm DNA fragmentation is borderline, the oocyte might be able to fix the sperm DNA fragmentation if it's not too high.
Yeah.
But the opposite's not true. If I have that patient with 36 to 39 to 40, in which the oocyte is much less capable of fixing the breaks that we have in sperm. So I think it's important to consider to individualize treatment for different patient scenarios. And I do agree with you, Sheena, that this is an important thing to consider. If the patient is over 40, I mean, this is quite hard because, you know, the aneuploidy rate is extremely high. And what we do for sperm, although it might help, it might be in some sense offset by the high chromosomal abnormalities that we see in the oocyte.
Yeah, okay. There's just one little question here, and that's about Klinefelter's. When you were talking about your sperm retrieval rate with micro-TC was 20 to 30% for Klinefelter's, what was the age group you were talking about? Because this question is beyond a certain age, you can get testicular fibrosis. So just wondering about that age.
Right, yeah, sure, absolutely. I think this is an important point. Usually the patients we see with Klinefelter syndrome, they come young. They come to the clinic, I mean, young. They are not patients because the diagnosis is made quite early. These patients usually have small testes, they have some testosterone deficiency. They go for the urologist because they are concerned about something which is wrong. And the diagnosis of zoospermia is made quite straightforward, and then the genetic analysis is done subsequently. So most of our patients with Klinefelter syndrome are below the age of 45, mostly around 30s, 35s. So we do not see elderly patients with Klinefelter syndrome. But I do agree that advanced age is something that has been shown to potentially decrease the sperm retrieval rates in Klinefelter syndrome patients. So we need to advise our patients that if they plan to have a chance of biological parenthood, they need to consider either, I mean, kind of having IVF sperm retrieval earlier, or eventually, if the patient's not married, to be counseled about the possibility of having sperm retrieval and freezing sperm.
Yes. Thank you. I think we should end on that note. Can't thank you enough. That's been so informative and so interesting. And I'll hand you back now to Eileen just for a few housekeeping points.
Yeah, thank you so much, Professor Esteves. You know, we could see just by the interaction how many questions. I think we could have went a lot longer, but I think people would like to get home as well. So thank you again. It was a great talk. And for everyone else, just a little reminder of what we have coming up as well. So we're joined by Professor Peter Himbledon, who will be talking about supersperm, DNA fragmentation, and the role of lifestyle. And that will take place on Tuesday, the 2nd of November at 6 p.m. BST or UK time, GMT probably by then. And then also on the Tuesday, the 30th of November, at the same time, we'll be joined for our very final webinar of the year by Professor Andrea Salonia, who will be just asking, is infection a common cause of male infertility? So if you haven't already registered, please do so online on our website. So thank you again, everyone, for joining. Thank you so much to Sheena and for Professor Esteves for our very global webinar tonight. And thank you, everyone, for bearing with us for some of the technical issues that we experienced. So the recording will be on the website tomorrow, and we'll send shortly out the CPD certificates after that. So thank you, and hopefully we'll see you at our next webinar on the 2nd of November. Enjoy the rest of your day.
Thank you very much. Take care. Goodbye.